Ladies and gentlemen, welcome to MedSynapse podcast series. I'm your host, Dr. Nigar, and today we have a very interesting topic to discuss. The topic of our discussion today is on navigating the depths of breast screening and high-risk assessment. Joining us today on this topic is Dr. Dana Haddad, a DHA licensed and American board-certified consultant breast radiologist with extensive expertise in breast imaging, oncology, and high-risk screening. Dr. Haddad, who completed her subspecialty training in oncology and breast imaging at the Memorial Sloan Kettering Cancer Center in New York, is also a PhD holder in cancer imaging. Her research focuses on cancer-targeting viruses and improving breast screening for high-risk populations. With her strong background in radiology and commitment to women's health, this podcast series likely offers very valuable insights into breast cancer awareness and prevention. Welcome, Dr. Dana.
Nigar, thank you so much for having me on today and to talk about a very important topic and a topic very close to my heart. So I really appreciate it.
Thank you so much for being there with us on this podcast today. Now, let's begin with our podcast. Dr. Dana, to begin with, could you please explain the concept of personalizing breast screening for high-risk women and why is it important in early detection?
Absolutely. So, Nigar, firstly, unfortunately, breast cancer is just very common disease, both in my own community here in Dubai and also just globally. It's the most common cause of cancer in women, and it's also the biggest cause of cancer-related death in women. So the aim of the game really is for early detection. And we really need to identify, especially women at high risk for developing breast cancer, in order to be able to detect cancers as early as possible before the patient even knows that something might be developing in their breasts. And in today's age with medicine, we are really moving towards personalized care, personalized medicine. Not every woman is the same. Not all women have the same family history or the same genetic components. So very important to identify women at high risk. And it's absolutely crucial for early detection of breast cancer.
Now, what are some of the factors that classify a woman as a high risk when it comes to breast cancer?
So there are several risk factors for breast cancer. When we're talking about general risk factors, what's really important to understand that the top two risk factors for breast cancer are being female and getting older. So that unfortunately affects all women, right? A very small percentage of breast cancers can occur in males, up to 1% of cases. But for this, the purposes of this podcast, I think we'll just concentrate on risk factors for women. So other risk factors includes a family history, whether you've had a personal history of breast cancer, high levels of alcohol intake, and also taking hormonal replacement therapy such as HRT and menopause. That can slightly increase your risk, although the medications now are much more what we call bioidentical to your body. So we feel that the newer generation medications are better, but we just don't have enough data to prove that it probably doesn't increase risk for breast cancer as much as we previously thought. But what makes a patient in particular high risk for breast cancer is mainly family history. If there is a genetic component such as the BRCA1 and 2, that's the main gene that we hear about in the media. I'm sure a lot of us have heard Angelina Jolie, for example, has been very active and a big advocate about knowing what your genetic status is. And she's actually a BRCA holder and has had a prophylactic mastectomy. So she's had removal of both breasts for prevention of breast cancer. But it's also important to understand that 75% of women who develop breast cancer don't actually even have a family history. So other factors also are how early you had your period, how late you had your first child. So these factors relate to the hormone estrogen. So the earlier you have your first period, the later you have your first child, the longer you're exposed to higher levels of estrogen at a younger age. So multiple factors that can increase your risk of breast cancer. But the last point that I'd like to also make is I think as women generally, we're very good at blaming ourselves for things that are really out of our control. And if a patient develops breast cancer, it's not the patient's fault. There are some things you can do to try to decrease your risk, but in general, those are the factors that could increase your risk for breast cancer.
Now, moving on to our next question, could you please share some insights into the latest advancements in breast screening technologies, and also how do they benefit the high-risk individuals?
Absolutely. So breast imaging has come a really, really long way. We started off with a 2D mammogram, usually read on film, and now we're kind of in the digital world where we can actually read our mammograms on high resolution screens. And so that's been a big advancement. The two major advancements in recent years have been as follows. So the first is what we call tomosynthesis, which is also known as a 3D mammogram. So this type of mammogram actually provides slices through the breast at 1 millimeter intervals with the mammogram or an X-ray. And we're able to detect much smaller cancers that we otherwise might not be able to detect on conventional 2D mammogram. And especially in a woman who has something called dense breasts. So dense breast means the ratio of fibroglandular tissue in your breast compared to fat. It doesn't have much to do with your cup size or breast size. It's more about the ratio of breast tissue. So that tomosynthesis or 3D mammogram is able to slice through the breast and be able to detect things at a much earlier rate, basically. Another big advancement as well in breast is breast MRI. So breast MRI has really only taken off in the last 20 to 30 years. And so that's actually a relatively new modality in the world of medicine. So breast MRI uses magnetic resonance. It's not radiation. And we use contrast through the vein in order to light up the breasts. And we are able to find things earlier on MRI that we otherwise would not be able to detect on a mammogram or even a breast ultrasound. So MRI has also been a big game changer in terms of how we screen women in general for diagnostic workup and problem solving, and also for early detection. Now, one thing with breast MRI is that we don't know if it saves lives. We know mammograms save lives. So every woman, every year is the recommendation that we provide to patients in order to save 40% of women from dying from breast cancer. Above the age of 40, a mammogram every year. If you are at high risk, we would add on the MRI every year as well. And we know that MRIs will pick up breast cancers earlier. So there's a bit of a stage shift. So your outcomes are better. You may need less treatment. You may even forego systemic treatment at that point. So in terms of breast, I think those are the two main advancements. And the third, more recent advancement is called contrast enhanced mammography. So for example, patients who can't tolerate MRI, who are, for example, claustrophobic, or just cannot tolerate a long procedure in a lying down in a certain position, we can actually inject contrast through the vein and do a subtraction image on the mammogram itself. And the data has been very, very promising, and we've been actually possibly able to replace the MRI and do biopsies under contrast enhanced mammography guidance rather than having to do, let's say, a procedure under MRI. So I think these would probably be the major advancement in high-risk breast screening.
Now, how can healthcare providers and patients work together to ensure a personalized breast screening plan that's both effective and safe?
I think that's a really, really good question. And I think it's something that we still need to figure out what's the optimal way to catch patients who are at high risk. So I think the biggest thing is communication, right? It always comes down to communication, education, and awareness. So for example, at our clinic, every woman that walks through the door, we're able to actually do a risk assessment. And we ask a whole bunch of questions in order to tailor her screening plan. So according to the American College of Radiology guidelines, women fall into three main categories. So The average lifetime risk for breast cancer in a population is about 12.5%. So that's that magic number, 1 in 8 women. 1 in 8 women will develop breast cancer in their lifetime. That translates to an average risk of 12.5%. Now, if you're 15% lifetime risk or below, then you're considered average risk. If you're between 15 to 20%, you're considered intermediate risk. And if you're more than 20% lifetime risk, you're actually considered high risk for developing breast cancer. So we use something called the IBIS model or the Tyrer-Krusik model. And it gives us that estimated lifetime risk for every woman that's actually getting her screening at our clinic. Once we obtain this, then it's very important to communicate that both to the patient and the referring physician in order to tailor the screening plan. So if they're high risk, you may need screening earlier. On average, we start at the age of 40. If you're high risk, for example, in the United States, they start at age 30 with a mammogram. So very important to come in and get that risk assessment and then communicate what that means to the patient in a reassuring manner. So your risk assessment is not supposed to scare you. It doesn't mean that you will develop breast cancer over your lifetime, but it's just a guide for us to know when to start screening women and with what modalities to screen women with as well.
Now, what are the unique challenges or considerations in customizing breast screening for high-risk women compared to the general population?
I think one of the biggest challenges is catching high-risk women in the first place. So a lot of women think that the only thing that's going to make them high risk is the fact that they, for example, have a family history. But in fact, if you take some of those risk factors apart, so for example, having an early period, having a late child, etc., it doesn't seem like a big deal. But if you combine several of these kind of risk factors together in one person, they could actually be higher risk and not even know that they're high risk. So again, that comes down to education and awareness and encouraging women to actually come in to get their screening, risk assessment, and mammogram. Risk assessments are not done in every clinic. It's time consuming. It requires quite a bit of knowledge and a bit of training in order to do it correctly. So that could be also another challenge. Obviously, cost, everything is a cost benefit analysis at the end of the day, and especially when we're talking on a population level. But more and more awareness is being raised. I think October Awareness Month is a great time to try to educate women and their families, communities around us about what it means to be high risk for breast cancer and how we can actually assess that and what needs to be done moving forward. And then the last part about this, the challenges in terms of screening high risk women are false positives, right? So when we, for example, do an MRI on a patient, the sensitivity of MRI is very, very high, and we may end up having a lot of false positives. So we would recommend a biopsy. We would perform the biopsy, and then it ends up not being a malignancy. So we would call that a false positive finding on MRI. So this is why we can't offer certain tests to every single woman. We have to offer them to women who are at higher risk in order to optimize that positive predictive value of the test. So I think that's also going to be a challenge. There's a lot of studies as well about patient anxiety. So recommending a biopsy, for example, for a woman, and that it might cause a lot of anxiety, and also the risks involved with a biopsy. But I would like to think that women would trade safety and health for possibly a period of anxiety until they actually end up getting the answer that we need. So I think these would probably be the main challenges, I think, in screening high-risk population.
Dr. Dana, you have mentioned about the role of genetics in personalizing the breast screening. Now, we would like to know how genetic information can be used to benefit the high-risk patients.
So genetic testing has really taken off as well recently, and especially due to advocates in the media who are open to sharing their genetic status as well with the world. So gene testing involves usually either a saliva test or a blood test. And actually, when we do those risk assessments for the women coming in through the clinic, the actual software would give us a probability of possibly harboring the BRCA gene. So we're mainly looking for the BRCA gene. There are also other genes that can also increase risk for breast cancer. But for example, if you have a 10% probability or above of harboring the BRCA gene based on your family history, if you know it, then we would recommend performing a gene test. So there's a lot of controversy around genetic testing. There's a lot of considerations as well. So for example, does the patient even want to know their status? That has a lot of implications for them also moving forward in life, etc. Would they be willing to actually share this data with their family and their friends? It becomes also an ethical dilemma, right? So for example, if a patient is BRCA positive, they have a 50% chance of passing that on to their children. And there's also a 50% chance that their siblings might harbor this gene, including males. So either brothers or sisters. But a lot of patients don't want to share their status. So they really have to think about these considerations. And then there's also considerations in terms of insurance and disability allowances and for health insurance. So if you are a gene carrier, unfortunately, we are still a bit behind on rights for patients in order to have adequate health insurance, having coverage for their insurance if they do have a gene mutation. So there's a lot of considerations for genetic mutations and gene testing. So in my opinion, the best way to go about it is to have a genetic counseling session with an actual trained counselor who will go through all of these issues with you, go through your family history, and then see whether you really are, it is really warranted for you to actually get a gene test. And for me, knowledge is power. The good thing about knowing your genetic status is that we can actually do something about it. And so, for example, again, for the BRCA gene, it increases your risk for breast and ovarian cancer. So many opt for prophylactic mastectomy or removal of both breasts for prevention. We're able to offer higher screening, more frequent screening, screening with MRI. And then there's also medications that you can take to lessen your risk. So I believe, honestly, that gene testing is a major revolution. It, again, helps personalize and tailor screening programs for women. But we need to pick the right people to undergo it and also know how to adequately support these women once they know their genetic status.
Now, moving on to our final question of the day. Could you please discuss the potential outcomes and impact of early detection through personalized breast screening for high-risk patients?
Yeah, I think as everything, there are positives and negatives to doing this, right? So positives, really, the main thing is early detection, better outcomes, empowering women to take care of their health. The earlier we pick things up, the better. So, with breast cancer, they used to say that early stage breast cancers are up to 95% curable. Now we're actually quoting up to 98% curable. So if we catch breast cancer at early stages, we just remove the area and women usually are fine and they go back to their life. So really the main aim is empowering women, early detection, making sure that they're healthy and happy so that they can take care of their families and, go after their dreams. And I think tailoring screening as well could actually be cost effective. So when you actually catch cancers at an earlier stage, you need less surgery, less treatment. So it's actually good for the overall health system in any country that you're in. But obviously, there's also negative aspects, including cost of gene testing, cost of surgeries, costs of medications. And there's a big debate about that. Like, what is the cost-benefit ratio? But most of the studies have been proving that the earlier you detect things, the better. It does actually pay off to make sure that we do have these high-risk screening programs in our respective countries. And then the last point is what we talked about before, which is patient anxiety. But I think, women really are not given enough credit. And I think women are very strong and they can deal with almost anything. And so a little bit of anxiety in order to make sure that you're healthy and for any early detection, I think is definitely worth having high-risk screening programs.
Dr. Dana, thank you so much for the interesting conversation and for sharing your expertise in this podcast with us today.
Thank you so much, Dr. Nigar. I really appreciate you having me. Thank you.
Pleasure is ours, and we're looking forward to many more podcasts together on our platform.
I hope so. Inshallah. Thank you. Shukran.
Shukran. And to our respected audience, before we conclude, we would like to give a special appreciation to you for tuning in with us. If you found this discussion valuable, don't forget to show us your support. You can like, subscribe, and also for medical professionals who are seeking to engage further, we invite you to register on our MedSynapse platform to become active members on our website. Thank you so much for tuning in. Stay informed, and until next time, goodbye.